presentation by Robert Gorter on the topic of how to boost your immune system to fight cancer. And it's derived from a book called Fighting Cancer, a non-toxic approach to the treatment, presented to the holistic health class at San Francisco State. It's such a pleasure to introduce my colleague and friend, Robert Gorter, who since the early 1980s was at UCSF working in studying the immune functions, especially of people with HIV. And how can you boost the immune function? And he has had massive experience at UCSF. And out of that, and in conjunction with his background being an anthroposophical trained physician, also a cancer survivor who now thrives, is sharing today his perspective, what we can do to optimize our immune functions, and if you get cancer, what we can do in a non-toxic approach. Robert, it's such a pleasure for you to come and share this information with my students.
Well, thanks. Thank you. Make me a little bit shy, but maybe briefly to my person, I'm originally from Holland, so you hear my accent a little bit, and so I'm a doctor trained in Holland, and I had a clinic there for anthroposophic medicine and a restaurant, and we gave cooking classes for healthy nutrition and so on and so on. I came to the United States in the very early 1980s, and I sort of fell right away with my nose in the HIV/AIDS epidemic. And at that time, very few doctors, also at UCSF, wanted to deal with patients with AIDS, because it was considered a gay disease, and who wanted to deal with gay men and so on. So, but I thought, well, I'm a doctor, so I take care of anybody. So I got really unintentionally in the beginning, I fell in the AIDS epidemic, and of course I'm very grateful because how we also had a large study. So for many years I was the medical director of the Department for AIDS Epidemiology and Biostatistics, and much of what is known about the natural history of HIV infection comes from our cohort. And there are a couple of things which were striking to me. And of course, one is that when HIV progresses and people develop AIDS, that most of the people have as the first AIDS diagnosis a malignancy, so cancer. Yeah, so it was clear that HIV would make the immune system fall apart, but especially that part which protects us against cancer. And the other thing was, that was at the time then a little bit later from Bill Clinton, but that it struck me that those people in the cohort who smoked regularly cannabis, that they much better. They were called the long-term no progressors. So I've always been saying we should also look at the beneficial effects in general, but also for the immune system for cannabis. So then I did some studies still at UCSF, also with dronabinol, THC, which is the component in the cannabis plant, which can make you stoned. But it has significant beneficial effects in cancer and AIDS patients. So more and more I got also involved in and then also better understanding how the immune system functions. And so what I have developed over the years, of course, with my team, is what we now call the Gorter model. And Erik Peper and we wrote this book together. And that is, and I do more the medical part, the medical side, the immune system and the cells and so, and Erik more how do I deal with the catastrophe and things like that. And the question, why me? Because anyway, so we work together, and we actually, Erik Peper and I, we worked together since 1984 when we met at San Francisco General Hospital, and we have always been good colleagues since then. So I also want to say it's my pleasure to work with Erik Peper anyway.
Now, Robert, thank you. It is a pleasure. And I have a specific question, because in a way, so many people have a sense that there's not much you can do for cancer, except to, almost you're a victim in a certain way. And you had a different personal experience when you were much younger as a medical I think just when you finished medical school. Maybe you want to share your experience And because I think that sort of colors the perspective, what happened.
Yeah. Well, of course it is so. No, I was just a medical doctor, and I was in the first week of opening my own clinic in the center of Amsterdam. And then I was diagnosed with an acute illness. And and I sort of knew this is wrong. And so I also wanted to be operated. So I had an abdominal operation, but under local anesthesia, because I already knew that you can have immune suppression just by a general anesthesia. So it was not nice to get your belly cut open under local anesthesia, but we did it. And then it was clear everything was wrong. So then I said, okay, thank you. So 2 days later, I pulled my infusions out, went on my bicycle back home, and I said, well, that's it. Then I'll do it my way, because I always was convinced chemo. I've seen in hospitals as a medical.
It isn't clear. What did they find when they operated, or what was the diagnosis?
Of course, they done also the pathology came 2 days later. They found a testicular cancer, very, very aggressive testicular cancer. So they also said, well, we can give you chemotherapy, and maybe you can, and I knew too, maybe live 2 months longer on the blood of another person. And I said, no, thank you, I don't want this. And if I have to go, I go, but I rather do it my way. So therefore, I treated myself, and for an actually final end-stage cancer, I treated myself with Mistletoe and with some fever treatment and something out of anthroposophy. And now that is now almost 50 years ago, and I'm kicking and so on. Yeah, and also the cancer was done. I didn't do scans because I thought I won't change anything. But after about a year, I had to have, because also my lungs were full with metastases, and I needed an X-ray to, and then it was completely clear. So nobody said anything. So I knew I had made the right decisions. So, and that, of course, I have developed over the years to improve our methods. And now we have had really 96% of all our patients who we treated in our way, they were end stage. They had no therapeutic options anymore, standard therapeutic options anymore. And, then you start looking in Google and what you do, and then they found us, and many of them who had really end-stage final disease are now 16 years down the road, 18 years down the road, and without any cancer. So I think we can really say what we do. Now, what do we do? Let me first say something else. The cancer, actually, we each one. So if you don't smoke and don't drink and don't do anything God has forbidden, you make, as an adult, at least 100,000 cancer cells, and they appear in your breast, in your prostate, in your brain, anywhere.
When you talk about that number, one sec, when you say 100,000, you mean a day, an hour, or what?
No, but 24 hours. It's estimation. If you live healthy and organic and whole foods and this and that, don't smoke, don't drink. So still, you will make at least, as an adult, and you weigh, let's say, 75 kilograms or 150 pounds, you make, really estimate, but you can also measure in the bloodstream about 100,000 cancer cells. If I smoke or drink or do other things, that will be maybe 10 times more. But so you can really say, even if I live like a saint, I still make cancer cells. So subclinically, we all have cancer. We all make cancer cells. That's part of the metabolism. That is through mutations. That's what is in your food. That is what comes from outside, radiation, name it, 5G, 4G, just name it. So, and then also X-rays. There are good studies showing that if you get a CT scan, that's published in the British Medical Journal, so one of the top 5 medical journals. And if I have also a healthy, but I have a broken leg or so, and I have a scan made for my leg, the chances that I get cancer increases with 0.5%. So if I have 5-6 times a scan for some reason, also when I'm not ill, then I have a significant chance to get cancer because of that. So we also have developed other ways of developing, like in diagnosis. but sometimes you need to know. So I'm not against an CT scan. I'm not against an operation, but you should weigh what are the pros and the cons. So we are not, so we are open-minded, but often it's not necessary. Now this is the thing. Only mammals and humans, I think you are more than a mammal, we have an additional part in the immune system. Let me briefly explain. Okay. The immune system, but everybody thinks, and that's true, it protects us against anything which comes from outside into me. Bacteria, viruses, maybe sometimes funny proteins or so, poisons. So the immune system is right away at it, and it will increase its activity, and that can only be by fever. And we all know when you get the flu, you have this or whatever, you're a little bit sick, you also have a fever. Yeah? And that's what you see even more in the United States, that fever is considered the cause of disease. But it isn't. It is an effort, a step up of your defense mechanisms, because if your immune system must be activated, must work harder, then that can only be done by increasing your body temperature.
So let me interrupt for a second, Robert. So you're saying basically that our arm of the immune system gets activated when our body starts mounting a fever. Correct. Then it activates our immune system. I mean, they work sort of together. And the more fever I can raise, the more likely will my immune system be competent to start recognizing and fighting, quote, external invaders.
Yeah, that's right. Of course, we shouldn't have 200 degrees. So 1.5 degree increase in your body temperature is perfect. Yeah, so that should actually be, and you should have that. There's many studies showing that people who have hardly any fever reaction to anything, they are much higher at risk for cancer. So you should have every 2, 3, 4 years, a couple of days of fever. You should have the flu, for instance. Yeah. So don't always get vaccinated against everything, because some of these, and also these viral infections, a newborn, in the first year, a newborn has on average 7 viral infections. Snot, there's a cold, and this and that, but they have a fever, and that's very important, because the immune system is sort of like aerobics for the immune system, and that's very important.
So if I interrupt you, Robert, then you're saying basically that the fever is an indicator of basically that our immune system is starting to work, and if we suppress that quickly with medications or antipyretics,
aspirin, ibuprofen, whatever it is,
then in some ways we're not mounting the appropriate immune response, and over time that could be deleterious. I mean, obviously you don't want to have a fever of 104 then you want to modulate that. That's different. But allowing a fever to be there and being well hydrated is in a way by which you support the system. So you're saying, in a sense, in the 2 arms, so that's one arm of the immune system.
Yeah, one arm. And that's also through antibodies production. And then the other arm, that is only developed in mammals and in humans, and we call that the cellular immune system. T cells and also dendritic cells, I'll explain that, are part of it. And these are part of the immune system, what can also recognize danger, not only what comes from outside, but also from inside, because cancer always comes from inside. I can never get cancer from my neighbor. Yeah, and so cancer cells, which can also cause my death, there is always a danger which comes from inside.
So what you're saying then, if I interrupt, that our body spontaneously, because of whatever reasons, mutations, produce cancer cells, and then our immune system, the second, which is common in mammals, it recognizes these abnormal cells as dangerous, and then they essentially kill them, or they induce apoptosis in them or something like that. They kill them.
That's right. Actually, it's slightly more complicated, but let me explain. So these cells which recognize bad guys, so to speak, Yeah, they're called the dendritic cells. And why they're called dendritic cells? Because dendros in Greek means branching, or the branches in a tree. And on a microscope, it also looks, the cell looks that way. And they crawl, we have millions of them, and they migrate through all your inner organs, looking for abnormal cells. Do they find one? Then they do a biopsy. It's really very nice. They do sampling. They take a few of these abnormal antigens presentation, abnormal pimples of a cancer cell, and they take a biopsy, and then they rushed to the next lymph node, and the lymph node you can compare with a military base. And in a lymph node where you're healthy, they're filled with killer cells. So with Marines, and they are ready and hopefully in good condition to kill, but they must be informed which cell they must kill. What is the enemy? So the dendritic cell, and one dendritic cell can inform about 5,000 killer cells, 5,000 Marines, by implementing a little piece of the biopsies they took. It's amazing. And then it takes about 2 to 3 hours, and then the killer cells know exactly, and also they know in which direction, which we have not understood. So they leave the lymph node, the military base, and they go right away to a cancer cell with this information. And then within 24 hours, 26 hours, this cancer cell is killed.
So what you're then saying really is something like the following. There's a dynamic balance in the body with an endogenous and production of cancer cells, which occurs all the time at different rates, depending whether I've exposed to carcinogenic agents or not, etc. And then the competency of my killer T cells or my immune system to identify, and when, so there are really two sides. If I have a lot of carcinogenic factors increasing the production of cancer, we want to reduce that. That's one side. That's like avoiding having pesticides in your food or other things, or too many x-rays or whatever, or maybe even G5 for brain tumors as a possibility. And the other side is, what can you do to enhance their competency of the immune system?
Yeah, that's what I want to do now to improve. Okay, you can say that when I develop cancer, when I now get clinically cancer, I get lung cancer, prostate cancer, that means the immune system is always failing. That means, and that can be on the level, as when I put it simple, on the level of the dendritic cells, so the policemen, they look for good and bad guys, that the dendritic cells need reading glasses, so to speak, or it is the killer cell. As an image, they're all Marines, they're in the military base, they're drinking beer, they're smoking pot, and they don't want to leave the military bases. Yeah? So there are two components which we always then tested. So we can first of all improve the Marines, that they're jumping to do something, and we do that with mistletoe. We did a nice study showing that because practically all patients with.
But what is, yes, but for just for clarification, what you're saying is that you can give a kind of herb or an extract of an herb of the mistletoe, which we use almost like the one we do for the holidays, where we meet each other and give each other a kiss, potentially. We take the extract of the berries, is that right? And
no, also from the leaves.
Of the, okay. And you then subcutaneously inject this, or how do you take mistletoe as tea?
Yeah, now mistletoe is also, then that mistletoe is one harvested in the summer and once in the winter. And why? Because it is the European or the mistletoe, so it has white berries. Also grows in the United States. I don't know if European settlers took it with them or not, that I don't know, but it needs a temperate climate. And then you see that in the summer, when there's a lot of light and warmer, it makes different components, different alkaloids or different polysaccharides than in the winter. So we like to harvest the mistletoe in the summer and in the winter, and we mix it, so to speak, in a special way. And then the ampules are made. And why? Because these immune active components, which can also improve natural killer cells or the function of the Marines, they are large molecules, about 120, 130 kilodalton, and they're like a little bit like glycoproteins. And if I would take them they are like digested like a small protein, so they must be injected. So the patients do that themselves, a subcutaneous injection, and what a diabetic patient does 3-4 times a day, you do that twice a week. But in the morning, I'll explain that in a minute. So the mistletoe has been used, especially in Europe, since 1923. Yeah, and so I think it's estimated about 6 million cancer patients in Europe are on mistletoe treatment. Yeah,
And so they do this then in a way, the concept is that enhances the killer cells, what you say, functionality, and possibly improves the temperature rhythm of the body as well?
Also, yeah. We also looked at, we did a university in Berlin, that we looked at cancer patients, and with a control group, we looked at cancer patients, and they always have a low core body temperature, usually at least half a degree or 0.8 degree lower in the morning than in average patients.
And is that 0.8 degrees centigrade or Fahrenheit?
No, yeah, it's actually centigrade.
So it's almost double then. It's almost like 1.5 degrees or 1.
Yeah, 1.2 degrees, I would say, Fahrenheit. So roughly like that. I'm a little bit unprepared to quickly rethink in Fahrenheit, but it's also the picture and the image. So they have a significantly lower core body temperature. And now normally, you and I hope, when you measure your core body temperature in the morning, it is more or less normal. So it's normal. And during the day, so by the end of the day, so till 5-6 o'clock in the afternoon, it reaches its peak. And then there's about half a degree or 0.6 Celsius increase of the body temperature. And then when you go to bed, so and so, when you fall asleep, then the core body temperature slowly comes down again to early morning. And you can put practically a sinus curve through it. And if you have that, you're healthy. We have never seen that in a cancer patient. Then it's more flat, and there is hardly an increase over the day. So they have almost a flat curve, a stiff curve. And Erik is an expert in rhythms, and when they are stiff, there's always a bad sign.
So in a way, what you're saying is that if I want to check that for myself in the morning, early in the morning, I could do a rectal temperature.
Yeah, must be a rectal.
So it's really true core temperature. You take rectal temperature, and then you do it every couple of hours for a 24-hour period almost. And what you should see is that you have a low temperature upon early morning, then it goes up, and eventually it starts going down again. And that is a normal rhythm. And that rhythm tends to be absent in people who have cancer, and as if the temperature never rises during the day for them almost.
Yeah, that's minimally 0.1 degree or so. Yeah, and that is so. But also, if you don't have cancer yet, it is also a predictor for getting cancer. Because if you don't have a circadian rhythm, then you are much higher at risk for cancer.
Yeah, and we know that in a sense that people who have many have time shift jobs, night shift jobs, or people who have lots of jet lag that is an increased cancer risk. Breakdown of binaural rhythms increases that risk. The question I would then ask is one.
But then briefly say also, it was always thought, because you see an increase of cancer in flight attendants and in pilots. And it was always thought, you're 12 kilometers or 10,000 miles up, you are more exposed, and that's true to radiation and so. That was the reason. But now the interesting thing is, and it was done over hundreds and hundreds of flight attendants and pilots, that when you're 10 hours or 11 hours above the clouds, 10 miles up, but you fly north-south, then you don't really have a jet lag. If there's 1 hour time difference, let's say from Amsterdam to Cape Town, that is or there's 1 hour time difference. Yeah. So on these, they had some increase from flight attendants in breast cancer, but not much. But if they would fly east-west, so let's say from Amsterdam to Los Angeles all the time, or to Shanghai, They were also 10 hours up in the air and exposed, but they were always in a jet lag. And they had, and also the pilots, a significant and statistically significant increase in cancer.
Yes, because yeah, and it would almost make sense because you're disrupting the biological rhythms, and that and we all know, you know, and that would is not totally, it would not be totally surprising. The question I would say is maybe you could quickly say what would be what is for the patients you worked with who were all stage 4, who really had no hope, what is the basic strategy for treatment? That's one. And then the second part would be what can we do preventatively? Because most of us as students or people, we may already have cancer, but we don't know it, and we're still seeing ourselves as healthy. And what can we do to stay healthy from these concepts?
Yeah. So it is also like what you said in the beginning, a balance. We all have subclinically a little bit of cancer. Yeah. So that's the issue. We have a little bit of cancer, but if we can fight it, you can turn 100 without clinically cancer. So, and now what can I first of all do if my immune system starts to slip? Yeah. So, and then of course there are many things you can do. Of course, first of all, look also at your nutrition and your lifestyle issues. And if you bring a little bit more rhythm in your life, or take away stress and so. But medically, what can you do? You can, for instance, then also take 6 weeks or 8 weeks off and on mistletoe. Because also Mistletoe, large cohort study with 18,000 people, now that's a very nice cohort, can show that you can also significantly lower the risk or prevent cancer. Yeah, and and also they did that is a couple of hundreds of identical twins, women who had this gene for breast cancer. And now, for some reason, one part of the twin would smoke, would do this, would do that, so and so, and the other would be much more health conscious, and so and so. And that was then often that the woman that who lived sort of against God's will, they developed. I can't hear you. I can't hear.
Okay, keep going.
Okay, and so that they were much higher at risk that the oncogene would then express itself and they would get cancer, and the twin, identical twin, exactly also the same oncogene, would not get cancer. Yeah, and therefore you see that of course your genetic makeup has an influence. Yeah, but also your lifestyle it also plays a very important role. So. And but of course, I would for sure recommend, first of all, then also mistletoe off and on, but also maybe to be more involved in artistic activities. The fact that you maybe under guidance in the beginning learn to know the world of color, yeah, and what it does to me, then also that will help and gives you a sensitivity, which is not only emotionally or and more balanced, but also for your immune system. And we can also really check that. So there are many things you can do, but it also depends what are you willing to do, and maybe what you are willing to give up. Maybe sometimes you have to give up something. Just think of smoking and give up something, but then get many things back for that.
So now, in a sense, if you think of the treatment you have developed, could you maybe want to share the major themes of that as a kind of non-toxic approach?
Yeah. Now, what we do when cancer patients come to us, after a blood check and also immune system and killer cells, and then we have like a protocol, and we treat patients first of all always with mistletoe, but also with certain antiphospholic medications. They are sort of homeopathic. And then also with fever. Now, if somebody has a tumor somewhere, or even a brain tumor, yeah, and let me say this, I just looked at our data again, glioblastoma multiforme stage 4, all patients
which is a brain cancer.
Yeah, brain cancer, but all the brain cancers, but especially one brain cancer, all patients die. Maybe half a year later, so, but they all die. And we have, in those cases where they're already end stage, they're dying, we have still 46%, so almost half, complete remission. yeah, that the cancer completely disappeared, the brain cancer, and that now we have patients up to 18 years now. They're kicking, they're back to the company, heading the company, and so on. Yeah, and we do that then also with local hypothermia. And now let me explain the local hypothermia. And that is developed by Siemens. That's a big, so like General Electrics in the United States. Siemens is probably the second largest electronics company in Germany, and they have developed a way that we bring through a tumor. Say special sound waves.
It would almost be like microwaves in a way,
Yeah,
right?
so in a certain way microwaves, but but in that direction, but it's not complete, but in that direction. Electromagnetic fields, but they're completely innocent, so everybody can sit there. It's no radiation, yeah. And now what we can do, even through the brain. With brain tumors, we bring this field, electromagnetic field, straight through a tumor or a couple of tumors in an area. And then tumors have always an abnormal protein makeup. And so there's more resistance. And now very selectively, only cancer cells, they are, through the resistance, I get friction, and then I get warmth development, but exclusively in a cancer cell. And then the cancer cell temperature goes up, and in about 20 minutes, the temperature is then 42, 43 degrees. And then each cell, also normal cell, but especially a cancer cell, is forced to make a lot of lactic acid.
So what you're saying, just to clarify, the temperature goes to about 102 degrees maybe or so, and in that process, because the metabolic
103 degrees, yeah,
the metabolic rate goes up, and the metabolic process of cancer cells is really different than that of normal cells. That normal cells, their end product is water and carbon dioxide, and in cancer cells, the mitochondria are disturbed, and that seems to be common to all of them, and their end product is lactic acid.
Yeah, and that's an acid. And then you see that exclusively in a cancer cell. A lot of lactic acid is produced, so the pH goes down, so it becomes more and more acidic in a cancer cell, and then the cancer cell dies because of its own lactic acid production. And we see that often, that maybe after 2-3 treatments, already half of the size of a tumor is decreased. Yeah. And so that is one major thing. And I will never forget that once a patient, an American patient from California, and she had extensive breast cancer with bone metastases, so cancer in the bone. And that is very, very painful. So she came to us in a wheelchair, but she could 20, 30 yards, she could walk with sticks, with canes. And then we treated her and so the first time, and she left to go back to her apartment, and she forgot her canes. Her crutches. And because she was so much better and less pain, because the amount of tumor was so decreased already in the first treatment, that she had so much less pain that she forgot to take her crutches. So that was also a sign for me, also for her, well, I'm on the right way.
Well, so in a way, you could say the hyperthermia, both local at a local tumor, or you could do a whole body hyperthermia where you're giving the person essentially kind of artificial fever to start re-evoking, triggering the immune response. And the sense of fever has been constant in much of medical history, starting with, in cancer treatment, with the work by Coley in the 19th century. Is that correct?
Correct. Okay, and also in the United States, hypothermia was the main treatment for cancer patients and was also pretty successful. All of you, also at San Francisco State University, at San Francisco General Hospital, they had a large cancer ward where the patients were treated, usually successful with hypothermia. But after the Second World War, now here comes, I don't want to make a socialist communist talk, but at the end of the Second World War, you had all these stockpiles of mustard gas for biological warfare. And the first 6 chemotherapy agents were made from mustard gas. And mustard gas kills yeah, any cell. And so, you see that actually more and more these treatments come. And I want to say one more thing, and then we have to go back to Rudolf Virchow. And Rudolf Virchow was really a giant and a pathologist in the 19th century in Germany, in Berlin. And also the university hospital is called the Rudolf Virchow Hospital. And he wrote a book. He looked his whole life under microscope. And he said, come to the conclusion, and that was also a great step forward. He said, look, cancer cells destroy tissue, healthy tissue. And that's why a patient dies eventually. So the logic treatment is to get cancer cells away. Yeah. And that's true, yeah, that's true. So operations, at that time they didn't have chemotherapy, but they had already hypothermia. And but an operation, I'm never against operation when it's easy to be reached, to take out a tumor. But that is only half the truth, because even each surgeon knows that if I take tumor away, I'm still at risk that it returns, maybe in another location, because the root of cancer is in the immune system. And when I damage the immune system because of radiation, your nutrition, genetically, whatever, then my immune system cannot handle too many cancer cells. So it is true that you want to get rid of cancer cells, but suppose I had this magic infusion, chemo, and would give the patient, all the cancer cells are gone. Within 24 hours, the patient has made at least 100,000 new cancer cells. So therefore, it is part of the truth, but you must never forget the immune system. And now the issue is that most forms of modern treatment, chemotherapy and radiation, suppress further the immune system. So you come a little bit between the rock and a hard place.
So then I would ask the question, in the treatment you have developed or supported, how do you now boost the immune system? And I know that you use whole body hypothermia, you do dendritic
cells,
vaccinations. Could you maybe just explain that little step, that the key we should be looking at is both how do we can keep supporting the immune system, and even you do this with people who are now stage 4, they have essentially gone through their normal chemotherapies or treatment and they're no longer successful, that when they do sometimes this, that for some of them, the cancer disappear as if they have new hope.
Yeah, but it would say quite a few, and then especially like also Klatskin tumor. I don't want to go now in details, because not from doctors talking, but that we have many forms of cancers where people don't survive. Nobody in the world literature has survived. Maybe lived longer, but never survived. And we could do this in a non-toxic way. That's important. And for instance, dendritic cells is also very, very safe, because what do? We take from the peripheral blood, from the arm. We take like 4 tablespoons of blood, and then we isolate a certain white blood cell, a monocyte, and they're almost still like stem cells. And we isolate those, and in a process of 7 days in a laboratory, high-tech laboratory, we can change those simple white blood cells, monocytes, into these highly differentiated dendritic cells. And then after a week, we have sort of like young policemen who just graduated, and they are full of vitality and ready to go, and they are given back to the patient. And then we like to do that 4 to 6 times. Therefore we call it a vaccination, because with vaccination you have to do the same lesson, so to speak, a few times, as memory cells.
But in many cases, the way you then do that is slightly different than many other people doing the process, is that you give the person at the first hyperthermia, in most patients, to increase their core temperature. The body is already more ready to have an activated immune system.
Exactly.
Right after the hyperthermia, then you would do the vaccination. Is that correct?
That's correct. So then these dendritic cells enter in a body where the immune system is completely activated and ready to go. And therefore also I think we are better than in the world literature, in all humbleness, but we combined it with hypothermia.
And what you then see is with those patients, those who get the dendritic vaccination, those who get a kind of very mild, almost like flu-like symptom for in the first 20 hours or so, that really is a very positive sign, because it says this, your system is really being activated. In the same way, when you get a regular vaccination, that if you get a little fever afterwards or something like that.
We call it flu-like symptoms.
Yes.
So usually all the patients do very well and respond, and often go in complete remission over years and years and years. They have always some flu-like symptoms. They're not sick, but they feel like, oh, I get the flu. And then for 6 to 8 hours, they maybe say, well, I skip my dessert, I skip my ice cream or so. But so they're not sick, but they feel off. They feel as if they get the flu. And then after 6, maximum 8 hours, it's gone. When I'm always happy, they know, so they always call me how it's going, and then they're jumping in their hotel bed or here or there, and they say, oh, I have some flu-like symptoms, because then they know that the chances that they will respond well increases significantly. So therefore, we are not afraid of fever, but of course, that should be within certain physiological limits.
So if we summarize the patients, basically, we keep going back. We have the one side of the equation, the risk of cancer, in a sense, or survival, is both the cancer burden you carry, how much burden you have, that's due to both environmental factors, genetic factors, etc., almost divided over your immune competence. And we should be working really much more strongly to build up our immune competence, because
exactly.
then, you know, our spontaneous cancer cells, our body can just deal with it.
Yeah.
And any other suggestions or hints how we can improve our immune competence?
Well, I would say also, but that's a hot topic, so I don't want to say too much of it because currently, but I say, trust your immune system if you have no big risk factors, and don't expect, I don't know, 10 vaccinations every year for this and that and so on and so. We should learn more to trust. Take care of yourself, and also, and if you have not a major disease, I would say also take care of your body, take care of your immune system. And if you once every couple of years you have a little bit of flu and you have a couple of days some fever, then you must actually be happy, especially when you otherwise have no underlying disease. Yeah. Okay. And also you look now in the current corona epidemics, those people who die are on an average 83. In Germany, in Austria, all the European countries, they're all 83. And so that means they're really elderly. So when you're 55, you're not at risk. You might get the flu, but you're not at risk for death, unless you have a significant underlying disease. Yeah, like severe COPD, or be smoking your whole life or so. So therefore, it is also, you must also look. Yeah, and the life is not without a risk. And if I say, and you that when you look at the cause of death, but now we'll stop. The cause of death, first leading cause of death is cardiac disease and blood vessel disease, and the second leading cause of death is cancer, and the third leading cause of death is medical mistakes, which were preventable. We have a nice word for it, doctors. Iatrogenic.
Or
I can't even say the word because I'm a doctor, so I don't like the word. But it means preventable disease. Yeah. So if the patient has a very big brain operation and dies, then that is not a preventable mistake. There were no mistakes. But if there was an overdose given, whatever, the preventable mistake, that's the third leading cause of death, also in the United States. Then you you see it's also that's known in Tel Aviv, in Seattle, in New York, that maybe doctors went on a strike for 1 or 3 months, that they did emergency cases, but all the ambulatory clinics were closed. Then you see a decline from 40 to 60% of all the people who died. So therefore, we should look at this data also, had to be the devil's advocate, that of course each doctor does what he can, but you should also see it in relation. So I still feel we should take care of ourselves, and also the immune system, and how I think and how I function and how it is in my heart, that I prevent or avoid hatred and so, and that's also ill-making and so, and therefore, and then I think we can live, but eventually at the end of each life, that is death. Yeah, and of course we want to live as healthy as possible, die when we're 300 years old, but you see what I mean. But still, at some point there is an end. Yeah, and when you're 83 on average, and you have already significant underlying disease like diabetes, COPD, severe heart disease, and then the flu gives you a little push across the border. Then I think otherwise the person a couple of months later would have died anyway. So that's also the consensus among many doctors, immunologists, epidemiologists, and so on, that it is, life also has a risk. But if you're prepared to deal with the reasonable risk, I think I would do that and not trust on the...
But what you're really saying is that what is demonstrated in many of the literature is, for example, of cancer, that probably 70% or more of cancer has environmental risk causes, whether it's the pesticides, whether it's the lifestyle, whether there are many. They're almost preventable. It doesn't mean we can totally prevent illness, but the real key is how can we live in a pattern by which we can optimize our health and our immune system. That probably means, in a very simplistic way, to have somewhat a regular life. That means you wake up and go to sleep in harmony with nature, in a sense, a little bit, that you eat foods which are healthy and not highly sugar only, or something like that, and low in pesticides, and that you have meaning and purpose in life. So you really wake up every morning and say, I want to wake up. I want to do something. Yay. And that quality will tend to support the immune system more, and that we live in a very strong, supportive social network, because that equally is helpful.
That's also what I would like to say, and make a point, that we not only try and take care of ourselves, but also for others. Because the social can also take care. If I see somebody is drinking non-stop Coca-Cola, just say something, zero Coca-Cola Light, then you know this person will get kidney cancer or this or that, so and so, and you can maybe once say, I care for you, and maybe you shouldn't do that. Yeah, so or maybe have orange juice. Just say something. Yeah? And
the
so
real
it's also
key, I would say the real key of all this is it is more like we can see these all as increased risks. There are people who drink 10 cups colas a day and never seem to have and be bothered by it. These are all statistical.
Not yet.
Not yet. That these are really the questions: what can we do to optimize or to reduce our own risks? And what you're saying, really, it's critical to take care to also help others, because as we help others, like agape, almost a sense of caringness for others, that also it helps them, but indirectly it nurtures
helps
us.
Me. Yeah,
exactly. We are all in it together. And maybe on that note, Robert, I think I want to thank you so much for sharing your wisdom and knowledge, and we'll see you in class.
Yeah, and one more thing I will say, maybe you can also give we have a website for students of San Francisco State, that is anthroposophical, that's health.
And I'm showing this here. It's www.anthroposophic-healthstudies.org.
Yeah, and there's a lot of information
on this perspective. Yeah. And so again, Robert, I want to thank you so much, and we'll see you on the 30th at San Francisco State on Zoom.
I hope so. Yeah. Okay. Aye, Captain. Bye. Bye-bye.